So yeah, I'm a researcher at the Scottish Learning Disabilities Observatory. The observatory is a public health observatory specialising in health and health needs of people with learning disabilities in Scotland. So this population face many health inequalities and are typically under-researched, and this is also a difficult population to identify in routinely collected data. So I'm presenting some of our work on behalf of my colleague Gillian Smith, who led the project but couldn't be here today. So people with intellectual disabilities are at higher risk of premature death, with higher mortality rates and lower life expectancy, dying up to 20 years earlier compared to the general population. They're overrepresented at deaths which are considered potentially avoidable. All-cause hospitalisation rates may be higher among people with intellectual disabilities, and that includes emergency admissions. They experience higher rates of ambulatory care-sensitive conditions, conditions which can be managed in primary care, and this often results in preventable hospitalisations. However, we don't have enough evidence on mortality and hospitalisations among children and young people, since data is not often separately reported from adults with intellectual disabilities. So this project aimed to develop an eCohort of children and young people with and without intellectual disabilities using Scotland's annual pupil census and record linkage between 2008 and 2015. So our specific research aims were to determine the all-cause and cause-specific mortality rates, standardised mortality ratios and rates of avoidable deaths in pupils with and without intellectual disabilities, to examine the hospitalisation rates for children and young people with and without intellectual disabilities, and to examine rates of ambulatory care-sensitive conditions and hospitalisations associated with these conditions. So today I'm just going to be focusing on the results from the mortality study, just due to time constraints. So we used education data from Scotland's annual pupil census between 2008 and 2013, which includes approximately 95% of school children in Scotland. And we identified pupils at school who were receiving additional support due to intellectual disabilities. So there's a mandatory record in the census for this. And we were able to see the pupils' age, sex, and ethnicity from the census and deprivation level. So that was based on postcode data using the Scottish Index of Multiple Deprivation. Using probabilistic record linkage, pupil records were linked to the Community Health Index to access several routine health data sets up to 2015, including National Record of Scotland Deaths Register, the Scottish Morbidity Records, including acute hospital admissions, and the Prescribing Information Service. That was to examine hospital admissions for 4 ambulatory care-sensitive conditions. So for this current study, looking at mortality, we extracted data on the date and age of death, underlying and contributing factors to deaths, which were provided to us from NRS via ICT codes. So the outcome measures that were examined for the study included the mean age of death, crude mortality rates, as well as the standardised mortality ratios. The causes of death allowed us to calculate the cause-specific standardised mortality ratios for both underlying and contributing causes using ICD chapters for the diseases. And for this study, we also examined avoidable mortality. We used the Office of National Statistics definition for children and young people to do this, and this classifies underlying causes of death into amenable to timely and effective healthcare, preventable through incidence reduction, or both. So we identified over 900,000 pupils in the census during the period 2008 up to 2013. So over 18,000, or 2% of children, had additional needs due to intellectual disabilities, and we assigned over 700,000 pupils without intellectual disabilities as a reference population for the mortality analysis. So there were some group differences. So the pupils with intellectual disabilities were more likely to be male, which is to be expected, and more likely to be residing in areas of greater neighbourhood deprivation. So there were 564 deaths in total. 0.6 of the intellectual disability population of pupils died, or 106 children and young people. And that was compared to less than 0.1% of pupils, or 461 children and people without intellectual disabilities. So this was a crude mortality rate of 157 per 100,000 pupils, compared to 12 per 100,000 in the control sample. The mean age of death was 2 years younger for pupils with intellectual disabilities at 14 years old, and half of the deaths from childhood compared to the controls, where more deaths took place in adolescence. Okay, so this shows the standardised mortality ratios for pupils with versus without intellectual disabilities. So it's been adjusted for differences in the age, sex distributions, as well as follow-up time between the two groups. So the top section shows all pupils, followed by children aged 5 to 14 and young people aged 15 and over. So the standardised mortality ratios were higher for females in both groups. From adolescence onward, there was a bigger rise in deaths among the controls, which contributed to the SMR being slightly narrower for young people. So next, looking at the cause of death, we were able to calculate SMRs for each chapter. So this plot includes cause-specific SMRs, which are combined for underlying and contributing causes. So once the contributing causes were included in the SMRs for diseases of the digestive system, this was very high due to how rare the conditions were on death certificates of children without intellectual disabilities, and included gastro acid reflux, gastroenteritis, and other treatable conditions. And the SMR for respiratory disease-related deaths was 55 times higher for children with intellectual disabilities, and included pneumonia, pneumonitis due to aspiration. And so even though external causes of death were the leading cause of death in the control group, the SMR was higher for external related deaths. So this slide shows the underlying causes of death in both populations, listed from the most to least frequent. So I'll just leave that there for a wee second, just so you can read through that. I just moved on to so this one shows all contributing causes of deaths in both populations, and again it's listed by the most to least frequent. I'll just leave that there for a sec. So next we looked at avoidable deaths and found that 19% of deaths were considered avoidable in the intellectual disabilities population. So 15% were amenable to treatment, and this included epilepsy, pneumonia, and aspiration. So that's food or drink going down the wrong way, causing infection or injury. Preventable diseases included diseases like accidents from choking. So in summary, the study found that there were 12 times more deaths in childhood and young adulthood in Scotland for people with intellectual disabilities, and the mortality gap is especially wide for female pupils and children aged 5 to 14. So for children and young people with intellectual disabilities, deaths were more likely to be related to certain diseases, including epilepsy, flu, pneumonia, aspiration, and contributing causes, including digestive conditions. So many of these were treatable conditions. And the results draw attention to common health inequalities experienced by people with intellectual disabilities who have complex care needs, so especially in epilepsy management, prevention of respiratory infections, including from aspiration and flu, and they also highlight important areas to be targeted by health and social care organisations to reduce premature mortality. So this study represents novel use of education records and record linkage to identify this hard-to-reach population. The potential is that it can be revisited in the future to take account of changes to policy and practice over time, and the study was able to look across the whole of Scotland. However, we didn't have a large enough sample to investigate increased risk in females, and we were also unable to adjust for the severity of the person's intellectual disabilities. So there are also known inconsistencies with using death certificate data, such as variation in diagnostic overshadowing for people with intellectual disabilities, and it doesn't include enough information of the person's death to look at those sort of details. So if you want to find out more about our research, you can check out our website, and we're also on Twitter. Thanks very much for listening. I just want to acknowledge that, so first of all, I just want to say this work is related to Dr. Flynn's work and colleagues So the methodology that used Scotland's pupil census to record linked to electronic pupil records with administrative health data sets. And finally, just to acknowledge that the study was funded by the MRC Mental Health Data Pathfinder Award.